When someone says diabetes, your mind immediately goes to sugar, right? But what if I told you there's another kind of diabetes, one that has nothing to do with the sugar and everything to do with a really strange hormonal puzzle? That's what we're getting into today, diabetes insipidus, and we're going to solve a pretty cool medical paradox along the way.
All right, to really get this, I want you to picture a number. 20 liters. Imagine peeing out 20 liters in just one day. I mean, that's over 5 gallons. And no, that's not an exaggeration. For someone with severe diabetes insipidus, that is their reality. It's just this constant, relentless cycle of drinking and then immediately losing all that water.
So what is this thing?
Well, the name itself actually gives us a huge clue.
You've heard of diabetes mellitus, right? Mellitus means honey sweet because of all the sugar in the urine, but insipidus, that means tasteless. And that's the whole point. The problem isn't sugar at all. It's that the body has completely lost its ability to regulate water.
Okay, so the root cause really boils down to one single super important hormone. It's called vasopressin, but you probably know it as antidiuretic hormone, or ADH. Think of ADH as the body's dam manager. Its one job is to tell the kidneys, hey, hold on to some water, don't let it all go. And when that system fails, well, the floodgates just swing wide open.
So to figure out what's going on, we have to play detective. We have to find where the communication broke down. And it really comes down to a fork in the road. Is the problem in the brain? The control center where the message is sent from? Or is the problem downstream, in the kidneys, where the message is supposed to be received?
Let's break that down because it's the key to everything. First, you've got central DI. Think of this as a supply problem. The brain, for whatever reason, just isn't making that phone call. It's not sending out enough of the hormone. Then you've got nephrogenic DI. This is a reception problem. The brain is making the call, the hormone is there, but the kidneys, well, their phone is off the hook. They're totally deaf to the message.
Okay, so let's tackle the first one, central DI. This is the more straightforward of the two, where the signal from the brain is just missing.
And what's happening here is pretty interesting. The hormone itself is made way up in the hypothalamus, and then it gets released by the pituitary gland. But in central DI, that whole assembly line gets broken. It could be from head trauma, a tumor, even surgery. Basically, the hormone factory is just shut down.
So the solution for this one is actually really logical, almost beautiful in its simplicity. If your body isn't making the hormone, you just give it back. The go-to treatment is a synthetic version called DDAVP, or desmopressin. And for most people, it's as simple as using a nasal spray.
And this is where the pharmacology is just so cool. DDAVP isn't just a replacement, it's an upgrade. It's been engineered to be better than what our bodies make naturally. For one, it lasts way longer. We're talking hours and hours. 2, it doesn't have that pesky side effect of raising blood pressure. And 3, it hones in like a laser on the exact receptors in the kidney that stop water loss. It's just a perfect, elegant fix for a supply problem.
All right, but now we get to the really tricky part of the story, nephrogenic DI. This isn't about a missing signal. Oh no, this is where we run into the great paradox.
See, in this case, the brain is doing its job perfectly. It's pumping out plenty of vasopressin, the hormone is flowing through the blood, trying to deliver its message. But the kidneys, they've got their fingers in their ears. They just won't listen. So giving more hormone is completely useless. It's literally like shouting at someone who can't hear you.
And this is the central puzzle, the big question. It's a real head-scratcher, right? How on earth do you treat a patient who is peeing out way too much water when their kidneys are completely ignoring the stop peeing hormone? What do you do?
Well, the answer is one of the most brilliant, most counterintuitive tricks in all of medicine. So let's solve this thing.
It turns out the answer isn't to shout louder. The answer is a clever workaround. It's a pharmacological magic trick.
Okay, get ready for this because it sounds completely backwards. The main treatment is a diuretic, a water pill. To treat a patient who's peeing too much, you give them a drug that makes you pee more. It sounds nuts, but here's the genius behind it. The thiazide diuretic makes you lose a little bit of salt. This tricks the body into thinking it's dehydrated. So to compensate, it starts reabsorbing way more water earlier in the kidney tubules. That means there's less water left at the end to be peed out. It's a brilliant backdoor solution. And then you have NSAIDs, which can help make the kidneys a little more sensitive to the hormone that's already there. And finally, a low-solute diet just means there's less junk for the kidneys to filter, so they don't need to use as much water to flush it all out. And this isn't some weird new idea. As you can see, this paradoxical anti-diuretic effect is well established. It's a classic case of doctors being clever, using a drug's known mechanism in a totally unexpected way to solve a problem that seems, well, unsolvable.
Okay, now for a super practical, high-yield clinical pearl. Because one of the most common reasons a person's kidneys become resistant like this isn't some rare genetic thing. Nope, it's caused by a really common medication. And that medication is lithium. A vital, cornerstone drug for treating bipolar disorder. But one of its major side effects is that it can cause nephrogenic DI. It makes the kidneys resistant to that ADH hormone. So, if we know the exact cause, is there an exact fix?
Oh, you bet there is. And this is where the pharmacology gets just beautiful. See, lithium gets into the kidney cells by sneaking through a very specific door, a channel called ENaC. Once it's inside, it just wreaks havoc. So the drug amiloride is like the perfect bouncer for that door. It stands right in front of the ENaC channel and just blocks it. Lithium can't get in, the cell is protected, and its normal function comes back online. It's that precise.
I mean, think about that. That's not a sledgehammer approach. It's a scalpel. It's like finding the exact point of entry for the problem and just shutting it down. It is a perfect example of precision pharmacology at its best. So all of this leaves us with a pretty cool thought, doesn't it? Diabetes insipidus is this incredible lesson that sometimes in medicine, the most effective solution is the one that seems totally, completely wrong at first. It really makes you wonder, what other paradoxical treatments are out there? What other problems could we solve if we just learned to think a little more backwards?